So I'm really pleased to introduce the next session, session C, on accessing data and building data infrastructure. I'm going to introduce the moderator for this session, Dr. Maggie French. Dr. French is an assistant professor in the Department of Physical Therapy and Athletic Training at the University of Utah. She received her DPT at Emory University and her PhD in biomechanics and movement science at the University of Delaware. Dr. French's research leverages learning health systems to understand variability in outcomes and healthcare utilization after stroke in order to improve the value of post-stroke rehabilitation. In this line of work, she combines her expertise in informatics, neurorehabilitation, and data science to address challenges facing clinical teams in our healthcare system. So I'm going to hand this over to Dr. French to introduce the session panelists.
Right. Good afternoon, everybody. Hope everyone enjoyed their lunch. So this morning we talked about selecting tools that we can use to measure patient-centered outcomes. And we then discussed how we should be capturing them within our healthcare system. And so in this session, we're going to be focusing on how we can access that data through our data infrastructure. There's no real right way to do this. And so we're going to hear from 4 different folks this afternoon about how their healthcare system is accessing their data. Accessing data may sound like kind of a nerdy session that we're doing right now, but it's really a pain point for a lot of healthcare systems on how they can actually get to this data that they've spent so much time figuring out what they want to collect and how to accurately collect that. So I think this is actually a really important session today, so I hope you guys all enjoy it. Like I said, we're going to have 4 speakers. Our first speaker will be Dr. Mindi Maines. She is the director of the Brooks Rehab Center for Outcome Analytics and Research, which is a department dedicated to advancing evidence-based and data-driven methods to support improved rehabilitation care and outcomes. Her research centers on the integration of healthcare informatics, data science, and research methodologies to enhance Brooks' learning health system. Our second speaker will be Dr. Timothy Marshall. He is the Senior Director of Analytics and Insights for Ivy Rehab. Ivy Rehab consists of over 560 clinics across 15 different states. In this role, Dr. Marshall leads a team of data analytics and data scientists to provide strategic guidance to improve patient outcomes. He earned his PhD in health science, specializing in movement science, and he has a master's of healthcare administration from Seton Hall University. Our third speaker will then be Leigh Harris. She is a physical therapist and manager of clinical quality and education at AdventHealth. She practiced in orthopedic and sports medicine patient care for over 20 years, and she's a past presenter at CSM, a member of APTA's Health Systems Network. And she's an integral member of the AdventHealth Sports Medicine and Rehab Clinics Leadership Operations team. And then finally, we'll hear from Dr. Ryan Roemmich. Dr. Roemmich is an associate professor at the Center for Movement Studies at Kennedy Krieger Institute and in the Department of Physical Medicine and Rehab at Johns Hopkins University. He's a human movement scientist interested in rehabs in people with neurologic damage and/or disease. And he's also the director of the Rehabilitation Precision Medicine Center of Excellence at Johns Hopkins. As with the other sessions today, we're going to hold questions until the end, and then we'll have about 20 minutes for questions and answers. And with that, I will pass it off to our first speaker.
Good afternoon, everyone. Can you hear me? Great. Thank you for the great introduction. Again, my name is Mindi Maines, and I work at Brooks Rehabilitation. I am the director of our Center for Outcomes Analytics and Research. But prior to my research position, I actually was part of our IT team. I was managing our analytics team. So I was really involved in the development of our data infrastructure that we use now to analyze outcomes through sort of our more research lens. So I'll be talking about integrating the data from the multiple EMRs that we use throughout our system to facilitate us as a learning health system. So just to give you a little bit of background on Brooks Rehabilitation, this is a diagram of our system of care. Brooks Rehab is a not-for-profit post-acute care health system, so we offer comprehensive services. We have 3 inpatient rehabilitation hospitals, and actually we're going to be building one soon, so we will have 4 in 2026. We have skilled nursing, home health care. We have over 50 outpatient clinics. And then we also offer a variety of different community service, community programs like adaptive sports programs, for example, throughout Florida. Our new inpatient rehab facility will actually be built on the Mayo Clinic campus in Phoenix, Arizona in 2026. So because we have, sorry, that looks a little weird there on the screen. Because of the healthcare system that we have pretty complex patient care pathways. So the journeys that our patients follow into, throughout, and out of our health system can be quite varied, right? In some cases, patients will visit our inpatient hospital. They will then need to go home and have home health services. In some cases, our patients will utilize only our outpatient clinics. And so one of the main priorities as we were building our data infrastructure was to be able to track our patients as they move through our system. And so our data infrastructure was really centered around this idea of how do we understand the health services that we are providing to our patients and ultimately their outcomes as they utilize our care, and also emphasizing care transitions and continuity of care as our patients move through our system. And so really that was the focus of how we build our data infrastructure. Although that is quite complex, because as patients move through our systems, they actually utilize different electronic medical record systems for each of our different care settings. So we have disparate EMRs for inpatient rehab and physician practice, a different one for skilled nursing and assisted living. Home care has a different EMR, and as does our outpatient. And so we have multiple EMR systems that do not talk to each other. So we have a lack of interoperability that makes it really, really difficult for us to transition our patients through our system and track them adequately. And so that's really where our data infrastructure comes in to be able to support that. So I really liked this article that was published in 2020 in Learning Health Systems Journal by Wooters and colleagues. This article is really kind of emphasizing the complexity of building a learning health system, and one I think kind of reflects our experiences. This is a really nice diagram because it kind of looks at advancing health system models. So the first level or lowest level of a learning health system, what they call comprehensive data learning health system. And this is one in which a continuous stream of data is systematically captured and that can be analyzed. Kind of next level to that is what they call sort of real-time learning health systems. So you're taking all those data that you've captured and analyzing, and you're providing real-time feedback to impact clinical care. And finally, sort of their highest level then is a full learning health system, and that's one in which you can do typical trial methodologies within your clinical care settings. So really what I kind of get out of this, right, is I think we're all kind of on different journeys in building our learning health systems, but the foundation of that is that we need robust data infrastructures to be able to support us at sort of whatever learning health system model we're at. I would say at Brooks, we're probably kind of between the comprehensive and real-time learning health system, kind of depending on the day or topic that you're talking about. So when I talk about health data integration, I did want to provide some definitions of what I mean by this. So I think that Peng and Bai offer really good a definition. They did a literature review on health integration, and their definition is that health data from heterogeneous or distributed sources are processed by certain approach to act as they come from one source in a seamless way. I think that's a really great way of thinking about it. We have all of these different sources, EMRs plus other data sources, right? Internal and external. We want to put them into one centralized location where we can access those data very easily for analysis or visual analytics purposes. So that's just kind of one component, though, of what is data infrastructure. So data integration, which I just kind of talked through, but there's other really important components of building a data infrastructure. Data standardization, I think we heard a lot about that, earlier today, of kind of what do we select and how do we put those data into our system, but also on in the back end, a lot of times we have to standardize those data to be able to integrate them together. Data security is also really important. Obviously, we're all working with PHI, sensitive patient information, but also in health systems, we have financial data, we have employee data as well. And so there's a lot of important considerations when it comes to data security when you're building your data infrastructure. And then, of course, data management. So we're pulling these all in together, but we really need an efficient way to store them, to retrieve them, to process and analyze all of these integrated data. So those really kind of make up the key components, which you'll kind of see later also tend to be our challenges as well. So this is just a schema of our Brooks data infrastructure. You can see it looks very similar to the image that I just showed from Peng and Bai, but really, kind of our first step is our internal EMRs, integrating those 5 different systems along with internal sources. A good example of our internal source is our patient-reported outcome system that we collect data on our patients using iPads. We also pull in other external sources. A good example would be our patient experience survey data that we collect in Qualtrics. So we pull all of those in. We do an ETL, which is extract, transform, load, process, and stage our data. And then we pull our data into our data warehouse. And this is really where our data is then stored and managed and accessed. From there, we can then do analysis, research, which is something that we're really on the path of starting, and reporting for operations and clinical purposes. I will mention we do have an internal application that we've built as well, which is called our Brooks Care Compass, and that interfaces with our data warehouse as well. And I'll talk about that in a little bit more detail in just a few minutes. So I did mention, the key components of data infrastructure. So what are some of the key challenges when we're integrating data? Data silos and interoperability tend to be issues. Of course, data transformation and standardization, data quality and integrity, data privacy and security. So you can see there's a lot of themes relating challenges to what the key components are. Cost and complexity, and of course, data governance and change management. And what we've realized moving kind of from our operational intent to more research purposes is that we're seeing new challenges arise when we're integrating data for research rather than clinical or operational purposes. So I thought I would just run through some of these challenges, these common challenges, and give you a few concrete examples of things that we're doing to kind of overcome some of them. So for the challenge of data silos and interoperability, obviously I mentioned we do have our multiple EMRs. We have developed internally an Enterprise Master Patient Index, or EMPI. This is an algorithm that we use to match our patient records across the different systems. So we utilize specific patient characteristics. We run some analyses on these to look at the probability that this patient in one system is the same as this patient in another system, and we map those. In some cases, our mapping isn't, of course, 100%, and we have a little bit of gray area. So in some cases, we do have our admissions team go in and double check to ensure that, yes, this patient actually is the correct patient in one system to the next. I did mention our centralized data warehouse. We follow pretty standard ETL process. We utilize a SQL relational database, a STAR schema, but really, it's built to be to be robust and scalable and flexible. We do all of our data transformation and normalization in-house, and then we use this data warehouse for our projections, for our analytics and reporting. So here's a good example of, I mentioned earlier that we are really focused on looking at our patients as they're transitioning into and through our system. And so we've built, using our internal data from our referral systems and from all of our EMRs, our patient tracking systems. And this is just one small image of our, what we call our Keeping Patients in the System dashboard. And really what this does is it ties together all of the patients from our patient journeys and looks at our Brooks to Brooks transitions. So in health systems like ours, patient retention is really, really key. We don't want patients to utilize our inpatient services and then go somewhere else for their outpatient care, right? Because we want to keep them within the system so we can have that patient continuity and ensure that they're receiving the quality of care that we provide. So this dashboard here, this is just, like I said, a screenshot, but really this is looking for our executive team to look to see our increase in Brooks to Brooks transitions year over year. And within this dashboard, we also have a way for them to really drill down to look at both sort of at the clinic level as well as sort of patient population level, to really identify areas that we may want to educate staff or change our referral processes to try to keep patients within our system. I mentioned our Brooks Care Compass. So this is a .NET application that we built in-house, and we have a dedicated developer for this system. And what this system does is it takes all of our integrated data into one centralized application, so our clinical staff can actually see where our patients have gone in our system and what services they have received. We can also, we kind of use this sort of like red cap in a way, where we also can build assessments within our own system, and so then we can collect information on our patients as well. So the image on the left there, that's just the image that we see as our patients are kind of transitioning through our system and certain patient characteristics. In the middle there, you see this is a communication tool where we are doing rounding on our patients, and we can let our teams know, hey, nursing found a delay, and we might want to round on this patient and follow up because we issued noted an issue, excuse me. And then, like I said, on the right there, this was a readmission review, and we can collect those data internally through assessments through the Care Compass. And again, these data are integrated with our clinical data warehouse. They go both, and it goes both ways. So some other solutions related to data standardization. So of course, any data infrastructure, you're going to need to do back-end data transformation. And you'll want to try to follow industry standards. And of course, we heard a lot also today about doing front-end data transformation to modify the front end of your EMRs, maybe adding discrete fields where possible, adding additional data collectors. We certainly need to do both of these and do them a lot. And then standardizing your outcomes. So this is one that I think we've all, been listening to quite a bit today. but for transforming our data to standardize across our system. So one of our major efforts is selecting certain outcomes that we want to collect on our patients across our system. So from inpatient all the way to outpatient. So our first phase was we completed in 2023, was a systematic review of all the outcome measures that we collect across all of our EMRs. Of course, as you can see with this shot here, we found considerable variability in sort of what and how outcomes are collected and through our different systems. This is just an Excel spreadsheet of all the different things that we found. Phase 2, we completed in July of this year. We took all of that information and we identified and required and outcome measures that we want to collect. So we took a programmatic approach. We focused on stroke, brain injury, and spinal cord injury, and we were looking at psychometric properties. Can it be tracked across our system of care? Is it reasonable and informative? And so we finished those decisions, and we will be implementing soon. Also on data quality and integrity, we do work really closely with our clinical and operational teams and they participate in data reviews to ensure accuracy of the data. We've also developed automated email alerts to help our teams identify when important data are missing from our systems. So these two screenshots here are actually emails that go to specific individuals to let them know, hey, we haven't collected information on diagnoses for our patient, for this particular patient, or this patient had a fall and we haven't collected the quality metrics data that we want to on this patient. And these go out every day. We also do proactive real-time documentation, what I call quote unquote auditing, but that tends to have sort of a negative connotation. And so really, I kind of like to call it proactive data quality. These are two images that are utilized dashboards by our inpatient therapy teams. The one on the left here is our therapy minutes tracking dashboard. And this dashboard shows patient level data for our therapy teams of all of the minutes of therapy that they have received across all disciplines every day. It also then projects whether or not the patient will be on target to reach their therapy minutes, their required minutes, by the end of the week. In inpatient rehab, we're held to a standard by CMS 3 hours per day. And so this really helps them to identify when we have documentation issues, if we've missed documenting therapy minutes, if we've recorded it incorrectly, they'll be able to track that and then also project out what the patient will be all in one dashboard. The one on the right here is our care tool tracking dashboard. We talked earlier today about GG scores. So this is kind of a similar dashboard that our therapists use to track our documentation and scores for at the patient level for our care tool mobility and self-care scores. So these are real time, and so they will go to them every day and they can look at them to say, uh-oh, we forgot to document walking on this patient. Let's go ahead and make sure we do that. So for us, like I mentioned, we have a lot more challenges moving from a data infrastructure focused on operations and really trying to also do research. So we're working next on establishing data use agreements and SOPs that's really going to cover our learning health system related data sharing activities. So that kind of falls under that data governance. We're going to continue with our standardized outcomes initiative with phase 3, where we plan to do our EMR builds. So we're going to have to take those standardized outcomes that we've identified and build them in our 5 different EMRs. We also want to complete a systematic review of our data that's collected sort of on health equity, our social determinants of health data. We know there's a wide variability in what we collect across our systems related to that information. So that's coming up. And then we really are going to be focused on developing a dedicated data warehouse that we're going to be used for research specific purposes. And our plan is to follow a common data model, likely OMOP, structural format. And so that's kind of in the works as well. And that's my references. Thank you.
Next. All right, well, it's good to be with everybody this afternoon. And actually, as I was reflecting on the introductions, it said 560 clinics. I guess at the time, that's where we were, north of 600 now. And so it's just, when we think about access to scale, it can be quite a challenge. And so one of the things that we're always thinking about is, A, how are we consistently collecting across the Ivy Rehab network? How are we providing access to that data to all of our clinicians within every one of our clinics, and also then to our researchers and administrators on understanding our data and driving operational changes. And one of the ways we've been able to provide that access is through making sure we standardize kind of one patient-reported outcome measure. You know, there's a lot, we talk about there's a lot of different patient-reported outcome measures out there, and we've really focused on just prioritizing one outcome measure across all of our adult ortho clinics. So of those 600 clinics, about 450, I think, are outpatient adult physical therapy and occupational clinics, and then the remainder clinics are Ivy Rehab for Kids clinics, so providing speech, occupational therapy, and physical therapy for our pediatric patient population. So across all of our adult ortho clinics, we really focus on standardizing one patient-reported outcome measure in order to make sure we're collecting that singular data point across every patient through every clinic, which then provides a really great value to leveraging that data to understand opportunities for driving kind of clinical improvement and quality improvement. And we really place an emphasis on the patient-reported side of things because we found in the conversations we're having with payers, they tend to be focusing more on putting the patient at the center, understanding what the patient's perspective are, because that's what's dictating what's going to happen next. A lot of the metrics that we're receiving back from payers is looking at the patients traveling through different other utilization of other healthcare services. And so really understanding from the patient's perspective is important for us at driving kind of our quality improvement. There's a lot of challenges, I think, with administering patient-reported outcome measures, and we had those challenges. We've been working through them over the past several years. One of those challenges has been very low response rate. I think historically we've noticed it's been hard to consistently collect a patient-reported outcome measure through all of our different patients. And that could be that the measures are too long. I think a lot of our standard legacy tools, 20, 30 questions, 40 questions, the dash is how many questions in length. And to sit there and collect that, have a patient complete a dash multiple times throughout the episode of care can be challenging. From the patients don't necessarily understand what it is that we're asking them through these standardized questionnaires. We'll have patients ask, well, I don't do these things, or I don't understand this. And so when you have very long outcome measures, we have found it challenging to help orient the patient to what the questions are being asked. And it takes a lot of additional time from our clinicians. The lack of poor integration has been a historical challenge within our PROMS into the EMR systems, because a lot of the systems that are out there, or the tools that are out there from independent companies, it's trying to make that connection between the EMR and that outcome system so that we can really pull that information into the system and make it really accessible to our clinicians and make it easier for them to create and launch those things. So these have been some of the historical challenges that we have faced with leveraging patient-reported outcomes. And so we've been doing a lot to kind of break down those barriers. And one of the things that we've done is a couple of years ago is we moved towards an outcome system tool that uses more computer adaptive testing. So which allows us to not only to take a historical patient-reported outcome measure that was 20 or 30 questions in length and really condense it down to 5 questions, as well as using the tool that we use, which I'll talk about in a little bit, allows also to use item response theory. So it kind of starts to personalize the questions that the patient is getting based on their response rates. And so we have found is that the use of a tool that uses computer adaptive testing has allowed us to improve our response rates, has allowed our clinicians to embrace leveraging that tool because of the way in which it decreases the administrative burden of providing the questionnaire, and has actually helped our patients embrace the questionnaire because it's the use of computer adaptive testing and the item response theory has allowed the questions to be distilled down to the ones that are more appropriate for the patient and eliminate the ones that are just not applicable based on how they've responded to the previous questionnaires. So the way in which computer adaptive testing works, just to kind of walk through for those who may not be familiar with it, usually you get this entry-level questionnaire. So just to back up, so what the computer adaptive testing does is it takes a legacy tool, let's just say the LAFS. How many questions is in the LAFS? If I recall, off the top of your head, 20, right? So it takes your historical item bank of 20 questions in the LAFS. And what it does is, starting there, it asks a mid-level questionnaire. So that how the questionnaire has graded out to be, this is a middle level function questionnaire. Based on the patient's response, and then we'll estimate of that initial entry level questionnaire starts to estimate where they should end up. And then we'll then tailor what comes next in the series of questions so that the next level questions is appropriate based on the first one. So for example, if the patient answers a high amount of difficulty at performing a mid-level questionnaire, it starts to filter out of that questionnaire sequence more of the higher level functional questionnaires. So the patient is not being asked, can you cut and participate in, or start to cut in sports or do sport specific movements if they have difficulty navigating steps. So it starts to eliminate some of those questions that may not be applicable, which creates a more personalized experience for that patient. And what also this allows us to do is determine through these different methodologies is calculate where the patient is and where they should start to end up by the end of their plan of care. So it gives us a barometer to say this is where patients like this patient should be, and then where they should end up. And then that allows us to compare where our patient is relative to the norm or other like-minded patients, and then where they should end up. So it gives us a target about the amount of improvement that they should experience over the course of their care. And so what the computer adaptive testing does is it kind of goes through these algorithms and stops when the algorithm is able to predict out efficiently where they think the patient will end up, and significantly cuts down the amount of time that our patients have to spend answering those questionnaires. Now, the tool that we use is one called PHOTO. It stands for Focus on Therapeutic Outcomes. It's just one of many that are out there. It's just one of the ones that we adopted several years ago. There's other tools out there, such as PROMS measures, other organizations that leverage PROMS measures, such as LeaRRn. That's another common company that's out there as well, that's leveraging computer adaptive testing. But what we have looked at is when we were evaluating the partnerships that we wanted to use for administering patient-reported outcome measures, we wanted to leverage something or have a partner that uses computer adaptive testing. And one of the great things about computer adaptive testing is, since it starts with a legacy tool, is that it'll give us this crosswalk score that we can connect back towards that legacy tool. So when we're reporting out our outcomes, we can give a crosswalk score to the legacy tool, as well as what PHOTO delivers is this functional status questionnaire. So really create some adaptability for how we want to report and measure our patients' functional status improvements over the course of care. The other thing is we fully integrated this outcome tool within our EMR. So we have set up a bi-directional API with our EMR. And so there is a lot of good reasons for this. When you're integrating computer adaptive testing into the EMR, which I highly encourage when trying to look at a way to, if you're looking at different systems to administer a patient-reported outcome measure, there's a lot of pros and cons to this effort. One of the things it does is significantly improves the clinical workflow. By fully integrating the patient-reported outcome measure into the EMR, that means that the clinician only has to stay within the EMR in order to create and launch any sort of patient-reported outcome measure. If we didn't have that fully integrated, bi-directional integration or full integration with the EMR, the clinician would have to go to an external source, and that creates a lot of extra things that they have to do to create, administer, and then even look at the data. So it improves that patient-provider engagement, because as the clinician is going through their initial evaluation they can create, launch, and even show the patient how they're doing right there within the system. Because when the patient-reported outcome measure is completed, it pulls in all that data right there to the EMR, so the clinician can just turn around their computer or pull up the PDF or show them the scores. And the other thing it does is improves the data quality. So by fully integrating it into the EMR, we're able to take all of the outcome data and associate it with very specific key patient identifiers that we can connect into the system that we can pull all the way down through different levels of our data organization or data structure. So when we pull it into the note, which I'll show you on the next screen, I think I've blacked out a lot of information though. We can show you how we've identified it specifically with some of our patients. One of the drawbacks of putting in those efforts is the cost. So a lot of these bidirectional or two-way integrations are not standard between an EMR and a vendor. And so usually the customer has to push a lot for trying to get that integration into play. And so the EMR may pass that cost into the customer to create that integration. It's a customization. It is worth the effort, it is worth the spend in our opinion because of the end result, which is improved user experience and better data quality. If we didn't have that integration, if you were to export the data out of the system of your other vendor, you have to figure out some way to mash it all together. And what you end up is usually one or two identifiers, and you have a lot of fuzzy matches. And so by that full integration, you're able to create a tighter connection between the patient-reported outcome measure and all of your other operational data. The other challenge is you become the technical SME. Since the EMR has never done this before, you have to create all the business rules and logics about how to make those integrations, how to create the data linkages within your system. And then you're also become the person who has to maintain kind of the working technical definitions about how this stuff is going to be joined. And then you have to maintain it over time. So here's just an example of how we've done this. So we can create and launch right from within our systems. This is a screen that our clinicians will see where they will create the patient-reported outcome measure right in the EMR. They can select the case types, the reason for why they're there, add any sort of secondary questionnaires that they would like, and then send it out to the patient or through QCDR code, just launch it right there for the patient to take it on their phone. And what we'll do is we will directly import it into the record. So by importing that data into the record, we can effectively join the data to all of the other operational data that is connected to that patient. And for us, we have the patient, the unique identifiers that we'll associate to is the patient number, the case code. So that's things like if it's the first time here, it's PT001. If patient comes back, PT002, PT003, so we can connect it to the number and the case code, and then allows us to create a join so that we can pull it all the way down through the level of data, other levels of our kind of data architecture. And here's just an example. So if we're trying to run different analytic projects and pulling from different tables of data throughout the organization, you have to join on a key identifier. And so by us pulling that data into the EMR, we're able to join that outcome data directly to that key identifier so that we can start to join these things to create different views of our data to run for analytics or to create different types of reporting dashboards that allow us to provide our clinicians access to the data in the field so that they can view their performance, or our data scientists access to the data to run advanced analytics. And this is just one of those tools of access where, because we're able to integrate our outcome data into our EMR, we can then join it with other areas of our patient care to create robust, interactive Power BI dashboards, so we can bring this out to the field so that they can view their performance across different areas of performance, such as their outcome score, looking at what % of patients end their plan of care early, patient feedback through NPS scores, as well as how long their patients typically stay. Now, like I said, 600 clinics. When we look at our completion rate, about 96% of our patients receive an initial photo on their initial eval, and about 81% receive at least one secondary questionnaire by the time they complete their plan of care. And so because we've made it very simple and easy, so for example, with computer adaptive testing, it takes about 1.5 minutes for somebody to complete an initial questionnaire, and 1.5 minutes again for that secondary one, versus the full PROM, it's about 5 minutes. We cut about 4 minutes off the completion time just by using computer adaptive testing and integrating it within their EMR. So be able to do that, we've been able to kind of pull this data together to really understand opportunities for improvement. And one of the areas that we've been really focused on is leveraging that data to drive improvement activities around reducing the percent of patients that end early through running different analytical projects. What we noticed was that we tend to do really well when patients complete their plan of care. When they don't, well, things don't go well. So we focus a lot of time on understanding who those patients are. So because of the efficiency at delivering or integrating this data and pulling it together, and it only taken about 1.5 minutes for us to answer these computer adaptive patient-reported outcome measures, it's freed up some more time for us to ask additional questions of our patient to round out our patient profile, particularly taking a biopsychosocial approach, so not just the clinical data, but understanding other areas of our patient, not just what is your pain on a scale of 1 to 10, but how do you perceive your pain impacting your ability to function? How are you coping with it, as we kind of create these psychosocial or patient personas so that we can predict the patient behavior. And so we've done this where we've been integrating this data to understand our patient personas to really drive quality improvement initiatives, such as decrease in the percent of patients that end early. And we've been delivering the information out through the field or out to the field through these interactive dashboards, providing them access to their performance and bringing those insights forward so that we can work on improving the experience that our patients have and helping more patients complete early. And we've seen a steady decline month over month over this last year, an improvement in our patient-reported outcome measures through leveraging our computer adaptive testing. So our next steps for an organization is we're going to continue to enhance the integration between the EMR and our outcome platform. It's not perfect. There's plenty of opportunities to make it more efficient. We're going to continue to use this biopsychosocial approach to round out these patient profiles so that we can get more predictive with our patient behaviors. And then understand, based on those profiles, understand what's the best approach to care to partner with those patients to help them complete their plan of care and achieve their desired outcomes. So questions will come next. Oh, thank you.
There we go. Okay. Okay. Good afternoon. I'm Leigh Harris, and I'm from AdventHealth. And I'm very honored to be here with you all today. I've learned a lot today, as well as from many of you leading up to the work that I'm getting to do with our system. I'm going to talk to you today about using existing outcome systems by a third-party vendor and how we utilize our data at AdventHealth. So just briefly, AdventHealth is a large integrated health system that spans 9 states. I am associated with the Central Florida Division, which is 42 outpatient centers currently and growing. And we're home there to three PT residency programs. In my role, I currently focus on driving implementation of best evidence care, and I work to influence our team to use our outcomes data to impact and inform clinical practice and improve value for our patients and system. My goals are to keep the data meaningful to the clinician and patient, while data experts like these here today help make that all possible. So today, as we focus on the power of patient-centered outcomes, I'd like to begin with a question. Outcomes systems, are we just peddling in outcomes or revving the engine towards value-based care? I am going to start with a short story. I have 3 boys, and the youngest, who is 5, just conquered the amazing feat of getting on that 2-wheel bicycle and pedaling. So yay, success. But as I watched, videoed, helped, and panicked a little bit, I kept thinking about how this was actually good imagery for my topic today. Achieving this 2-wheel outcome was marked with a journey of patience, focus, and skill development. So starting with the images left to right, this may be a familiar progression of learning to ride a bike. The tricycle, typically the best starting point for training, stable, built for the novice, but a bit awkward, like collecting outcomes on paper, which is where we started, as many of you. 3 wheels, this could be an option for transition, is slower, requires a wider turn radius, and there actually are 3 opportunities to need repair and pop a tire. This may represent a little bit of relative to using a third-party vendor where it's an outside solution. And then 2 wheels. Oh, the freedom we gain when we hit those two wheels. We can go on new speeds, the tires are aligned, integrated, we are more agile, and we can move faster along the path, but there are still limitations. With this increased agility, we have to stay balanced and increase our focus. And this is related to our own integrated systems, maybe locally, that you all are doing. Two wheels are a great step in the progress, but we need to do even better, and I hope to challenge us with that today. I will take a moment to reflect on the learning health system image on the left. It's already been shared today, but we see and know that the clinician and the patient are at the center of that. Our data must be functional and close to them in this vital connection while we try to remain focused on important priorities on the right. The data needs to be accessible to inform clinical practice and continue contributing to evidence in our field. The data must be easily captured and visualized for the clinician to receive feedback and with minimal burden, which we've heard about today. It should be assisting us to positively impact our patients, health systems, and the profession. And in regards to quality, we need to make sure that data is helping us demonstrate value that reflects quality and service over cost instead of just cost. And we do have the opportunity to allow clinical practice and the art of intervention to feed our data and impact quality. But we know it requires clinician engagement for this to happen. And I'll share our existing experience with using that existing outcome system and a little bit about our commitment to the quality through clinician engagement with the data. So for AdventHealth, Sports Med and Rehab, the acronym AWESOMER, we like to call it locally, I'd like to take a moment to just share our team's commitment because we've had a history and a journey like many of you have. The leadership and team have been committed to improving clinical practice and quality for some time now and have gained influence within our system in regards to outcome collection, data, and utilization and patient engagement. Key areas of the commitment I have listed here are we do have roles driving quality like myself, leaders, a research manager, and clinical educators. We've really worked hard to have a culture where the providers are engaged in knowledge translation and implementation of best evidence practice and based on data where we see places we need to dig in. Support from our vendors and IT, of course. Really important processes at all levels of care, from the front desk to the back end clinician and all the work behind the scenes with data. And then using that data to improve care, as we've said, and inform it. And then making certain our feedback is timely for the patient and clinician on the quality and impact of their care to bring value for every patient. So we will walk through a small journey map to just so you understand why we landed on this third-party vendor and utilizing an outside source. It'll explain the how and why. Moving left to right along this timeline, we started with pro choices for the team, moved to consistent tools, and quickly learned that clinician buy-in was a struggle while collecting paper tools early on. There was no good or efficient way to bring data into their workflow or offer meaningful feedback to the team on their efforts. 2016 to 17 was really a critical time for us. We performed our first knowledge translation project on cervical pain for our orthopedic team on data that we extracted painstakingly from our disparate EMR at the time via Excel data sheets, but we did it. This project was impactful, but for the frontline team to receive meaningful feedback and remain engaged, we knew we had to find a more rapid and manageable platform to help make the entire process successful. So in 2018, we actually were able to move to the Rehabilitation Outcome Management System as our vendor for digital data capture and useful data visualization. It gave us the ability to offer meaningful feedback to our patients and team that inform their care more rapidly. A few reasons why we did choose this was that it was simple and very clinician focused. It was intuitive for the front line, so it was easy to use in their practice, even though it was a separate login. It was developed by trusted quality leaders in our field, Stephen Hunter and Gerard Brennan and the Intermountain team. The data was used and focused on impacting care and elevating quality, which aligned with our goals and approach. And there was global benchmark data, which was available among the pool that were in this registry and contributing. It was not direct comparison, but as a roll-up, it really helped facilitate quality improvement, collaboration, and sharing of our efforts. And there's a unique opportunity to connect in a monthly community of outcomes user meetings, which allowed for collaborative sharing of learning and ideas. We have remained on this legacy platform, even though it has changed ownership about 4 years ago. But with industry and vendor priorities shifting, where payers work to have greater influence on the goal of our outcomes data, we know we must move on to the next phase in this journey and look to and influence our EHRs as our vendor. We need one standard place to see and do everything. Previously, AdventHealth did function on several disparate EMRs as well, but about 2 years ago, all of AdventHealth did transition to Epic. So we're just at the point now where we're getting to work to optimize that and hopefully help to influence them and optimize their platform for outcomes. So, but before we jump into that next bubble on that journey map, I would like to share the current functionality our team does have to go through with a third-party vendor system. It's served us very well for many years, but there are definitely limitations. Left to right there on the top, our clinicians have to log into the ROM system to capture and visualize patient feedback info on their Pro. We have to then log into a data visualization dashboard, which is QuickSight at this time. We, myself and my team, have to work to build data sheets to help trend the data for leadership and the team. Then we share feedback with the clinicians and leaders because we know they become disengaged with multiple logins to multiple platforms. And we must make certain they receive feedback, though, because we know that helps continue to drive improvement in their care. Each step limits efficiency and effectiveness for the team, as you can imagine, and it makes the data distant to the front line. So we need to take active steps and make it passive by embedding it in their workflow, and that is our goal. I'll probably say this a few times today, but I urge us to remember that the further the data is removed from the clinician, the less meaningful it is and the less impactful it is to clinical practice. Though not integrated, one of the most important feedback resources in our current legacy system for the patient and clinician is this patient report graph. If you can read briefly, it's going to depict the improvement or change in their outcome score and then the change in their pain. They're easy to understand graphs of the patient's improvement on both of those, which offers point of care feedback and fosters therapeutic alliance between the clinician and the patient. They just turn it around and talk to the patient about how they're doing that day and the progression they've had. It's a tool that is accessible. It's not as easy as we would like it built into the EHR, but they're already logged in for the day, and it's a great way for them to see the quality that they are delivering and inform their care. It is meaningful for the clinician and patient and opens up great conversation. So where engagement drops off dramatically is with the additional login to a third-party vendor data site. This is just one image of a page on our current data visualization platform. It's helpful data, of course, and information, but it requires time outside of the busy clinician's workflow, and its distance from the front line leads to disengagement. We need to do better than this, and we can. Okay. We are making progress as we work towards ease of data access for our team. This is a snapshot of a recent dashboard advancement using data from that third-party data system that we pull over manually. Within the last year, our department was finally able to bring on a clinical data analyst, and this is a sample of a dashboard he has created for us. Leaders are accessing this operational dashboard to visualize multiple areas of their business, including outcomes, and it doesn't require separate login. It is a central data point for the team. Definitely a step forward, but it is of limited scope. We're only sharing outcomes data within our team and sports med and rehab centers, and there's no benchmarking. We are trying to make sure, though, that perfection does not get in the way of progress towards the goals and just keep pedaling forward on that bike. Okay, as we work to move into our future state next phase, I do want to pause and say it's vital to remain focused on some guiding principles. In our APTA's Guide to PT Practice, it actually spells out the intent and goals of outcomes, that measuring outcomes is a critical component of practice, that they are important for a direct patient management, that they provide an opportunity for the profession to collectively compare and determine effectiveness. The data should help guide practice, generate benchmarking reports, and help shape payment policy. And standardized measures should provide a common language to evaluate success of physical therapy. In a recent article in Harvard Business Review titled "Patients Need a System to Compare Healthcare Quality, Not Just Prices," reminds us where we need to focus. So how do we pull all of this together and arrive at our ideal state, or Stephen's vision, as he shared earlier? I'm on board with that. I'd like to start with some goals that I think we should focus on the left and move across the chart. Ultimately, I think we all want value to reflect the highest quality care at the best possible cost. The data needs to be integrated into our workflows, systems locally and hopefully nationally, and has to allow point of care impact. The platform must be frontline clinician influenced and have a common standard language to specifically classify patients. And benchmarking really needs to be available for our clinicians and our profession to maintain optimal engagement. Some more benefits of achieving these goals in the center is that quality will hopefully be more important than cost. Data will be embedded in the workflow and be easier passive collection and visualization for the provider. The platform will be closer to the clinician and clinical practice, and engagement will inevitably increase. Challenges with remaining in this current state for us is that currently value seems to be equivalent to reactionary measures of cost and margin. Data is inefficient and difficult to access, as I've shown you, leading to disengagement. Many platforms are designed by non-clinicians and may have a profit focus, which additionally leads to disengagement. And data is siloed to individual systems, which leads to disengagement and limitations on general improvement. The harder we make it, the more disengaged everyone becomes and the data isn't utilized. The more streamlined and functional, the better. So using our EHRs as our vendor can optimize this standardized workflow. So what are our next steps to help keep the data meaningful, close to the patient and clinician, and effective in driving quality? I'd like to petition today for influential outcomes drivers like you to improve our engines so we can reach our collective next phase in this journey and help define a value accordingly. We need standard language to classify and define patients. We need it to be embedded in the workflow, benchmarking across health systems to drive quality and value. We want to help be proactive in payment reform. And how can we be influencers to help the value equation on the right? Keep pedaling if you're on 3 wheels. You are making progress. If you are already zipping along on 2, congratulations. Let's look at how we can move to a collective effort and standardize our approach. We at AdventHealth, and amongst some of these there are a few other leaders in the room that have done so as well, we are on Epic now. So we've joined their pro subcommittee through their Rehab collective, and we are collaborating and working to hopefully influence their approach to outcomes and reporting to build more powerful and valuable engines for data collection for their system. So if you can, think about how you can take steps to influence your system or practice or EHR, and maybe we can make a collective effort on reaching those goals. So as we continue to focus on the power of patient-centered outcomes today, I'd like to emphasize that the more we can improve the ease of the collection and data visualization for the clinician and patient by building better engines, the faster we can realize these goals and one day really reach that value equation we're after. We'll get a little dirty, but it's going to be fun. Thank you.
All right. Good afternoon, everybody. And thanks. I'm Roemmich. I'm an associate professor at the Kennedy Krieger Institute and Johns Hopkins University School of Medicine right up in Baltimore. Thanks to the LeaRRn team for putting this together, and thanks to Maggie French for inviting me to talk. I'm going to go off script right away, which may or may not be a good idea, but I feel a little bit like a wolf in sheep's clothing or something, being here and not having a capital T in my credentials behind my name. So I thought maybe I would tell you a little bit about how I got into this work. So my background is in engineering, and I started by always wanting to be involved in healthcare. And as I started to learn more and more, I started volunteering in a rehab hospital. And I thought that my career would be basically working in that setting, developing new rehab technologies or working on new ways of delivering rehab that would be innovative and would help people to move better. And that's what I started doing in my PhD work. My lab now basically does 3 different things, or my research has 3 different arms. Now that I'm on faculty, we still do some of that work. We also develop some different computer vision and AI technologies for rehab applications, specifically focused on motor assessment. But what I'm going to talk to you about today is actually my involvement in our Rehabilitation Precision Medicine Center of Excellence at Hopkins Medicine. And so that started back in 2017. And when that got started up, Director of our department at the time, and when he was getting that up and going, he invited me to come kind of sit in on those early meetings and help to get things up and going. He was interested in potentially using some of the measurement approaches we have for measuring movement kinematics as part of the center. And so I took that opportunity and learned more about what a learning health system actually was. And it didn't take much convincing for me to realize the magnitude of the opportunity that was involved in helping to facilitate these types of systems. And so for those first couple of years, I was kind of like the little brother in like a coming of age movie or something, where I felt like if I just kind of stood against the wall and didn't make too much noise, maybe they'd let me hang around and keep learning more about how to do this. And so I did. And I've been the director of the center for a couple of years, and I was the scientific director for a couple of years before that. But so what we're really interested in doing is, and what I'll talk about today, is bringing in multimodal data sources to be able to make predictions about patient trajectories over time. And so before I start, the team that you see up here, and this is not, I realize this isn't even comprehensive of our team any longer at this point in time, but any level of success we've had with this initiative has been due to these people that you see up on the screen here. And so you can see this has been due, the type of team that we put together is really comprehensive of a variety of different domains represented, both within rehab, but also beyond. We have representation from pulmonology up here on the screen. We have representation from physiatry, rehab psychology, physical therapy, occupational therapy, movement science. And so that's just to say that this collective effort that we've been able to put together has been really helpful for being able to push these initiatives forward, because we do realize that we need a combination of all of these different areas of expertise to make this successful. We need the technical side of things that comes along with technology development and engineering. We need the clinical side of things that comes with all of the clinical domains that I just mentioned. And then we also need the organizational side of things. And that's where Hopkins as an institution has really helped us to advance our initiatives. We work really collaboratively with several different institutes within Hopkins to make sure that this happens in an efficient, effective, and safe way for protecting our patient data. So to begin, and I won't talk too much about this because there's been a lot of discussion today already about how to standardize data collection. We've also put together a standardized battery with our team at the Sheikh Khalifa Stroke Institute at Hopkins Medicine. We have, our institute provides comprehensive care across the continuum, inclusive of acute care, inpatient rehab, and outpatient rehab. And across that continuum, we collect different measures at different points in time. We put together our battery to be representative of the different domains of the ICF model. And so you'll see body structure and function measurements, activity measurements, and participation measurements. And the different measurements are taken by different groups of clinicians. A lot of the lower extremity measurements are taken by PTs. A lot of the upper extremity motor assessments are done by OTs. And some of the cognitive testing is done by SLPs. And so once we have this data, what we wanted to do, and this is going to be the focus of my talk today, is put together a comprehensive data lake that contains all these different data sources in a way that's accessible and also easy to kind of combine. We wanted these data to be interactive and not just live in different silos where maybe you could access the clinical motor data over here, but then you'd have to go to a different silo to pull the cognitive data. And then, as I'm going to talk about in a few slides, we also wanted to bring in data from outside of the clinic. So we didn't want to have to rely only on what's being collected using this standardized battery, but we wanted to have that to be able to live right alongside data that we can actually pull in when patients leave our healthcare system to move into the real, I should tell Steve, I don't say real world anymore because Steve Wegner made the point to me that clinical data is real world data too. So now I've been saying data from outside of the clinic. So data from within and outside of the clinic. But how did we set up this data repository? First, we had to work with a lot of the regulatory bodies at Hopkins to be able to establish this and use this clinical data to put into our limited data set. So we worked with the IRB and the Core for Clinical Research Data Acquisition at Hopkins, or the CCDA. This helped us to define our population, which in our particular study is focused on people with stroke who've been in the Hopkins healthcare system since 2016. We had to then identify and extract that data, and of course, take into important considerations for protecting the patient's rights, like HIPAA waivers and waivers of consent. There we go. Okay, and so we have EPIC at Hopkins, so we use EPIC for our cohort definition. What that means is we can first go in and find a documented specialty service line that we're targeting to extract the data. An example here that I'm showing you is an outpatient service line, an outpatient physical therapy note. We can then find the admitting surface, like here in neurology and neurosurgery, and then use the ICD-10 codes to make sure that we're extracting data that are relevant to a diagnosis of stroke. What this has resulted in is our growing data repository that currently has 15,805 persons with stroke in it. And what we can then do once we have those patients identified is go in and bring out all these different data sources that we're interested in pulling to do our research. So here is just some basic kind of representations of our demographic data that we're able to collect, things like age at time of stroke, sex, or race. We also collect functional measures, as I showed you earlier, here showing some AMPAC scores that Danny Young had talked about earlier today. We have a wide variety of comorbidities. We bring in data not only from what's collected in the rehab settings, but if we need data on comorbidities, we have access to many of those type of data as well. We can get data on healthcare utilization. And so there's been a lot of talk today about common data models. We're starting to use some of those technologies as well, so that if we are working with data that's been collected, for example, for billing related purposes, we can also use that alongside of the clinical outcomes data. And if we use a common data model, it doesn't necessarily matter if we're using our healthcare system, another healthcare system. Hopefully, I think what the goal is for the future is that everybody will be able to kind of standardize their cohorts in a way that these different data sources coming from within or outside of your own healthcare system can be compared in an apples to apples way, where we can start to make sense of all these different types of data sources that could be relevant for how we're understanding the value and impact of the care that we provide. There's been some, I forget to talk earlier, somebody had mentioned some geocoding data. One of the benefits of being at our institution is that our Rehabilitation Precision Medicine Center of Excellence really falls under the broader umbrella of the Johns Hopkins InHealth program. And so what the InHealth program is at Hopkins is the larger precision medicine umbrella. So I think at last count, there were 27 different precision medicine centers of excellence there. What that really allows us to do is have access to other cool stuff that people are doing in precision medicine, even if it's outside of the rehab domain. And so we collaborate really closely with a faculty member in neurology who's been able to actually bring in a lot of this geographic information. So if we have this clinical data that we're collecting throughout rehab, we can also pair it with, for example, the ADI of that patient or from where they live. And so this has been really useful for us as well. We have a couple of projects going on related to social determinants of health that have been possible because of the integration of this data from outside of the clinic. Okay, and so I've talked about a couple of different data sources, and then the first step is to basically bring all of these into our data lake. So our data lake is this big living repository that, as I mentioned, has clinical data, billing data, and remotely collected data, all within the same centralized repository. And the battery is running low on this PC. I just got a notification, but I think it'll be okay. So this is all living inside of this centralized data repository. And so the next step is, as our session is kind of centered around, is if you have all this data in there, how do you actually start to access it? And so what we had to do was work through several different sub-projections, which were protocols that we submitted to the IRB. First, we established what we call an E-Form-R, which is an overall protocol set to establish a living data repository. So that just allows us to put all this data into one location. It doesn't allow us to do anything with it yet. But then what we can do is we can go in and we can submit other protocols that then allow us to use that data, whether we're submitting a secondary data analysis. If we want to pull existing data from within that repository, we can write protocols that ask specific research questions and request specific pieces of data for us to be able to analyze. And we can also submit prospective protocols. So as I'll show you on the next slide, if we're collecting data remotely from something like a wearable device, we can then pipe that data right into our repository as well and be able to pull it to ask research questions right alongside all of that clinical or billing data. Okay, and so what does that remote measurement of function that we're bringing in, what do those remotely collected data look like? We've been working primarily in 3 domains that we think contribute to kind of this idea of whole person function. First, we collect physical data. Oops, here we go. It's lagging a little bit there. Using wearable devices. And so we have minute-by-minute Fitbit data that's inclusive of both minute-by-minute heart rate data and minute-by-minute step count data on over 100 people with stroke now and 100 people with chronic obstructive pulmonary disease, and also about 30 children recovering from concussion. And that's collected over the course of 1 year. Over the course of that year, we also administer monthly psychosocial assessments and quarterly cognitive assessments. The cognitive assessments, we've used a variety of different techniques. I'm happy to talk to you offline about what we've learned there. We do both a combination of using online web applications and also some telehealth visits to collect that data. And then we collect PROMS measures to get psychosocial information on our patients. And so how do we actually use that data? We bring it all into our remote data repository using an automated remote monitoring application. And so that actually interfaces directly with these servers that bring in that data from the devices. So if the device comes in from the Fitbit and lives in the Fitbit server, this application can go pull that data automatically. And not only can it pull the data automatically, we can set it up to help with quality control. So for example, if a participant hasn't synced their Fitbit device within 5 days, the application will automatically notify that participant to do it. If they still haven't synced it within 12 days, it'll remind them again. If they haven't synced it within 19 days, it'll contact our study team to reach out to that participant directly. It will also then take this data and bring it in that repository, as I mentioned, to live right alongside the clinical data, the electronic health record that you see here. Just really briefly, what can we do with this type of data? These are some Fitbit data that we've used to do some clustering in individuals with stroke. This is to feed into one of our goals of being able to identify clinically relevant subgroups. On the x-axis here, you can see mean steps per day. And on the y-axis, you can see a variable that basically represents what does someone's heart rate do when they actually do start to move around. If they take a few steps, how does their heart rate respond? So ideally, you would want that measure on the y-axis to be as low as possible. By doing some clustering analysis, you can see from this Fitbit data, we can extract these 3 different subgroups that can be classified in the kind of the pink that you see there as an active group, the blue where their heart rate response is relatively low in response to the activity, but also not very active. And then what we think is the more problematic group is the group in green where they're not very active each day. And when they do move, they have a relatively high heart rate in response to that activity. Why am I showing you this? Well, what we can actually do with our data repository, because these data live right alongside our clinical data, we can then take these subgroups and actually start to look at some of the clinical data that we're collecting and see if these subgroups have any clinical relevance. And so here, when we look at those subgroups, we could see that they actually differ on their AMPAC mobility scores. And this is all possible, again, because these data all live within that same centralized data repository. The last thing I'll show you quickly is also because these data all live in the same place, we're working toward being able to provide clinicians access to this multimodal data that we're able to centralize. What you see on the top is a comfortable gait speed measured by a 10-meter walk test longitudinally over time for one patient. And with this new longitudinal viewer that people like Kelly Daly and some of the members of our Technology Information Center team, along with Maggie as well, have been working on recently, we can take this and we can actually then display directly to the clinician not only measures from the clinic like that comfortable walking speed, but here you can see steps per day on the bottom from that Fitbit device. And so we'd love to be able to display this to the clinicians who are interested in seeing, okay, how's my patient been doing over the last month, even if I haven't seen them in the clinic? With that, I will say thank you.